It's my pleasure this morning to introduce our speaker, Dr. Garrett Griffin. Dr. Griffin is a facial and plastic surgeon with Midwest Facial and Plastic Surgery and Aesthetic Skin Care in Woodbury and Eagan. He got his undergraduate degree from the University of Richmond. He went to medical school at the University of Virginia and then did a residency in head and neck surgery at the University of Michigan. He was subsequently awarded a research fellowship at the NIH studying the potential use of electrical implants for facial paralysis, and then did a fellowship in facial and plastic surgery in Los Angeles. Dr. Griffin will be speaking this morning on the diagnosis and treatment of facial paralysis. Dr. Griffin?
Thanks so much. Thanks for having me. This is a somewhat unusual diagnosis in adults or children, and basically the differential diagnosis is largely similar, except in the very young child or infant. And so there is a lot of information that does relate to adults, but all that information is applicable to children as well. As Joe had said, I did my training in head and neck surgery at the University of Michigan. That's where I really got interested in facial paralysis. I had a mentor there, Jennifer Kim, who just had a real passion for caring for this patient population. And facial paralysis is, I think one of the most devastating conditions you can have. It has many functional consequences in terms of having difficulty closing the eye and causing difficulties with speech and eating. But I think even more devastating is the kind of social ramifications. It's very difficult to smile. And even if you have some facial movement, you usually can't express the emotions that you're trying to express. And so many of these patients really become agoraphobic and stop leaving their homes. And there are interventions that can help most of these people. And because it's such a rare diagnosis, a lot of physicians don't know what's available. And so, my goal today is just kind of to educate providers to really show them what is possible with this patient population. My fellowship, I spent a lot of time at the Facial Paralysis Institute in LA, which is one of the, I'd say, 5 busiest centers in the country for facial paralysis. And I received excellent training there as well. So as I'd said, facial paralysis in children is largely the same differential diagnosis as in adults. Recently, there has been sort of a division of terming facial paralysis in the very young child as congenital causes, which would be something that was acquired while in utero, something like an infection such as syphilis, or trauma during the birth process, versus developmental, which would be something genetic or some sort of insult like a stroke while in utero. And the upside for facial paralysis in children is there's usually more interventions available for them, and they usually have better outcomes. So just quick definition, paresis means partial paralysis. Paralysis means complete flaccid paralysis. If there's one thing that I want people to take away when I speak to them is just that not all facial paralysis is Bell's palsy. Does it have an acute or chronic onset? Bell's palsy always has a very acute onset. Is it static or progressive? A slowly progressive facial paralysis is not Bell's palsy, and it's something bad, like a tumor, until proven otherwise. And are there other systemic or neurologic findings which might lead you to, a diagnosis of something more systemic? So just really quick, the definition of Bell's palsy is a unilateral facial nerve paresis or paralysis that has acute onset, going from normal to its maximum facial paralysis in 72 hours or less. And it's idiopathic, meaning we truly still don't know what causes it, and it also implies that you can't find any other medical cause for the facial weakness or paralysis. In terms of the pathophysiology of Bell's palsy, we think it's related to a herpes virus infection or reactivation of the facial nerve, which causes the nerve to swell. And the facial nerve passes through a bony canal at the skull base that's less than 1 millimeter wide. And when the nerve swells, we think it basically just shuts off blood supply to the nerve. And then the nerve basically undergoes what's called Wallerian degeneration distal to that point. And the nerve, can and almost always does regrow. Patients with Bell's palsy will have other symptoms other than just facial weakness due to the fact that this is a pretty proximal injury in the facial nerve. If you remember your facial nerve anatomy, the chorda tympani nerve basically comes off the facial nerve in the middle ear space, and that does provide innervation to the lacrimal gland and salivary glands, so they may notice dry mouth or dry eye as well. Back to not all facial paralysis is Bell's palsy. There's a huge differential diagnosis. When I was in medical school, I learned the Vindicates mnemonic for facial paralysis. And there's several things under each of these categories. So if you're talking about vascular things, stroke is obviously a can't-miss diagnosis as a cause of facial weakness. And, recently I've had internal medicine doctors ask me how they can differentiate Bell's palsy from stroke. Stroke should spare upper facial movement because that centrally you do have bilateral input to the forehead muscles, and so they should be able to raise their eyebrows if it's a stroke. Infectious causes, Bell's palsy I would consider an infectious cause. You have Ramsay-Hunt syndrome, which is a reactivation of zoster, so basically shingles of the face, HIV, meningitis. I'll talk about Lyme disease a little bit because we're in kind of a Lyme hotspot, and that's something you don't want to miss because it's treatable. Cancers at the skull base, benign tumors of the skull base, a variety of somewhat unusual degenerative diagnoses like Guillain-Barré and Melkerson-Rosenthal syndrome, which I won't bother telling you about because it's pretty unusual. Iatrogenic causes, so surgery for a tumor. I will talk a little bit more than I usually do about congenital or developmental causes because of the audience. Autoimmune diseases like sarcoidosis and multiple sclerosis can certainly affect the facial nerve. Car accidents causing temporal bone fractures, any sort of penetrating trauma to the face can injure the facial nerve. My roommate in medical school actually was cleaning his ear and ran into the wall, and he did not cause himself facial paralysis, but he did actually injure his ossicles and have quite a bit of hearing loss. So people do silly things, and you can damage the facial nerve. We don't see thalidomide exposure very much anymore, but that was associated with facial nerve abnormalities. Neurotoxins like Botox. I do a fair amount of Botox for people with Bell's palsy or for cosmetic reasons. In that case, we're trying to paralyze, the muscles that move the face. And then psychosocial reasons, really it's exceedingly difficult to fake a facial paralysis for obvious reasons. So that's not commonly seen. Just a little bit kind of more signs and symptoms of some of the causes that I'd like you to be aware of. Multiple sclerosis, just to review, this is more of a relapsing, remitting type process, not an acute change that's stable and then recovers like with Bell's palsy. And typically they would have had some other neurologic changes in their past. Sarcoidosis can be bilateral. You can actually do a blood test for ACE, which is abnormal in about 2/3 of patients. Mobius syndrome is a relatively unusual syndrome that I'll talk a little bit more about, but that we think is due to some sort of brainstem trauma during in utero that causes 6th and 7th cranial nerve palsies. CULP is an acronym that stands for congenital unilateral lower lip palsy. Again, we think a lot of those cases are a brainstem lesion, although it certainly could also be due to agenesis of the depressor anguli oris muscle, which is a muscle that pulls down on the lip. This is a picture of a child with CULP. Ramsay-Hunt syndrome. These patients typically have, like other shingles patients, severe pain. They'll often have a vesicular eruption in and around the external auditory canal, but they don't always have a vesicular eruption. And so some cases of quote-unquote Bell's palsy are probably zoster sin herpetae, are basically zoster without vesicles. Otitis media, if you have a bad enough acute otitis media, it can certainly cause facial paralysis. We talked about HIV, syphilis. Neoplasm is pretty unusual in kids, but certainly can cause facial paralysis, trauma, stroke. So, Bell's palsy does happen in kids, and it's, overall the most common cause of facial weakness, so I do want to focus on that a little bit. And the American Academy of Otolaryngology just came out with sort of consensus guidelines on diagnosing and managing Bell's palsy, which I think are useful sharing. So the epidemiology is about 10 to 50 cases per 100,000 person years. And then Kaiser Permanente a few years ago actually looked at just the under 18 population, and they reported that the incidence is actually quite similar in children, even though we don't really think of children as getting Bell's palsy. Risk factors include pregnancy, severe preeclampsia, obesity, hypertension, diabetes, which is most of America, unfortunately, and upper respiratory illnesses. It's quite common for the patient to recall discomfort around the ear before the onset of facial weakness. About 30% of people will not progress to full facial paralysis, so they'll have some movement left, and those people have a better prognosis. As I mentioned before, dry mouth and dry eye are quite common, and Bell's palsy has a spontaneous recovery, and the onset can be anywhere from a few days to 6 months. The sooner you start recovering, the better the outcome. So this is, I think useful stuff in terms of saving healthcare dollars and thinking about Bell's palsy. So if you have a classic story for Bell's palsy, so acute onset of unilateral facial paralysis over 72 hours or less, and there's no other symptoms or signs that make you worried about anything else, you don't have to get any labs, you don't have to get any radiography. But make sure you've really gone through the differential diagnosis carefully in your mind. And steroids, recommended treatment is prednisone, 0.75 to 1 milligram per kilogram, up to 60 milligrams a day for 5 days, and then taper over 5 days. The sooner you start, the better. However, even if you don't see them within 72 hours, it's probably worth treating these people because overall steroids are well tolerated, even in children, over this short of a course. And if you have a bad recovery after Bell's, it's quite devastating. Steroids are, likely considered safe in the third trimester, which is a relatively common time to have Bell's palsy. I'll show some data on the next slide about large randomized trials looking at steroids and antivirals. In adults, the number needed to treat to probably get a better outcome is 26. And there's really no data in children specifically as to whether adding antivirals to steroids improves the outcome. But it does at least cover you in case it's actually Ramsay-Hunt without vesicles. And so, I personally recommend doing steroids and antivirals for everybody. And then you just always want to think about their eye. If they can't close their eye completely, then while they're sleeping, their eye's probably not closed completely. And over the short term, dry eye and corneal ulceration is probably the biggest risk to these people. In 2007 in New England Journal of Medicine, and then the year later in Lancet Neurology, there was 2 separate large randomized double-blind placebo-controlled trials. And the criteria for a good outcome was something called House-Brackman 1 or 2 out of 6. 1 is no abnormalities, 6 is complete facial paralysis. 2 means that there's maybe the subtlest asymmetry, but really, these people aren't particularly bothered. And in the Sullivan study, they found that, all these people were treated within 72 hours onset, but they found that prednisone basically sped recovery and that the ultimate outcome was improved in patients. And then the Engstrom study, they basically showed, again, there was a shorter time to recovery with steroids. This is an interesting study from 1977 looking at 1,000 people with Bell's palsy that were not treated and were just followed. And it basically shows that 85% of people are going to have a good outcome, so that House-Brackman 1 or 2 outcome. And the other really important take-home message I want to convey is that no one with Bell's palsy should not recover at all. So if you have a patient with complete flaccid paralysis, 6 months or more out from onset, they don't have Bell's palsy. They have something else, and you have to look for another cause. Most patients are going to, 95% of patients are going to have some recovery starting within 3 months. And then if you look, basically everybody who it took longer than 3 months to start recovering had a bad outcome. So again, the earlier you recover, the better the outcome. It just is a marker of how damaged the nerve was. And then fortunately for, people who take care of children is that the younger you are, really, the better the outcome. And so young children have the best outcome, and really once you're, over 60, typically have a pretty poor outcome. Nerves just do not regenerate as well in adults, particularly older adults. This is just a picture of, a Ramsay-Hunt patient you might see, some vesicles around the extraocular canal. The pain is more common, the pain is usually more severe than you see with Bell's palsy. And they also tend to get involvement of the vestibular cochlear nerve more broadly, so they can have hearing loss or vestibular disturbance. Tend to have slower onset of recovery and a worse outcome. So only about 60% have a satisfactory recovery versus 85 to 90% with Bell's palsy. These people can get post-herpetic pain just like anybody else who gets shingles. And I do strongly recommend a zoster-cidal dose of Valtrex or acyclovir, as well as that prednisone taper for these patients. Lyme disease, this is a map of 2012 cases by county. As you can see, we are in a very hot spot of Lyme disease. I'm from here. It's a little bit of a hot spot. And so, the three classic symptoms are, target, rash, this is facial paralysis, and then arthritis. The laboratory workup, which I honestly don't know if I've ever ordered it, but we should all be aware of how to work it up. It's basically a two-stage testing with an ELISA first and then a Western blot similar to HIV. And it is treatable, so always think of this in any patient with facial paralysis, and it can cause bilateral facial paralysis. But it's basically relatively straightforward antibiotics by mouth for 14 days, as long as they don't have meningitis or radiculopathy. If they do have meningitis or radiculopathy, then it's an IV treatment. And then if they have arthritis, then it's recommended they actually get a longer course of 28 days. Acute otitis media, pediatricians see this all the time. Otolaryngologists see this all the time. Facial paralysis from acute otitis media is very rare, but it does happen. Again, fortunately, it's very good prognosis. The treatment is just myringotomy to relieve the pressure and antibiotics like you would normally treat acute otitis media with. Chronic otitis media, things like cholesteatoma, also can be associated with facial paralysis. A little bit worse outcome. It's probably related to, sort of the toxic environment and inflammation of the chronic low-grade infection you see. But they do, have a good prognosis also, as long as you do appropriate surgery and improve the condition. HIV, I won't spend a ton of time on this. HIV is neurotropic, we think, so basically, it can cause facial paralysis just by causing inflammation or infection of the nerve. And then HIV is associated with these other conditions like Guillain-Barré, lymphoma, other infections that can affect the skull base and can cause facial paralysis that way. Neoplasm, not something you guys usually are going to see in children. I do a lot of skin cancer reconstruction, so I see big skin cancers on the face. But children do get melanoma. And that certainly can spread to the parotid gland because there's lymph nodes in the parotid gland, and that can in turn invade the facial nerve as it passes through the parotid gland. So something to think about. In children, lymphoma and leukemia are a little bit more common than these others, which are a little bit more common in adults. And so always think about neoplasm. So I mentioned at the beginning that there has been a division recently of facial paralysis in the very young child into congenital and developmental causes. If you're thinking about, congenital causes, particularly birth trauma, which does have some medical legal implications these days, things you might look for, which you guys probably already know, which would be hemotympanum or blood behind the eardrum, bruising over the mastoid, and then a history of forceps delivery or prolonged labor is also, a risk factor for trauma to the skull base or the soft tissue of the face, which could cause facial nerve weakness or paralysis. If you see bilateral facial paralysis in a young kid, it's almost always developmental, so some sort of syndrome or trauma to the brainstem or brain in utero. So again, I was focused a little bit more on some of the more unique causes in childhood for you guys. So Mobius syndrome, relatively rare. We think it's a vascular insult to the brainstem during development. They do have, near normal and normal intelligence, which something I always try to remember with any sort of syndrome. The kind of constant thing you see is bilateral 6th and 7th nerve palsy. And so, 7th nerve, they basically have masked faces. They have a very restricted range of facial expression and usually can generate no smile, like no upturn of the mouth whatsoever. And then the 6th nerve palsy, the abducens nerve, they can't look laterally. It can be associated with other cranial neuropathies, as well as Poland syndrome, which is chest wall abnormalities, so absence of the pectoralis, or syndactyly, as well as limb abnormalities. This little guy has some absence of fingers. And in young children, some kind of things that might make you think of Mobius syndrome are difficulty breastfeeding just because they can't control their lips very well because they have bilateral facial paralysis. Just an absence of expression with crying. Difficulty closing the eyes, which again is probably the most important thing to think about and address so that they don't get corneal ulcerations and loss of vision. And these kids will, kind of move their entire head to look around because they can't actually shift their vision from side to side. Charge syndrome, originally known as charge association. Now we think of it more of a syndrome, and the charge acronym came from colobomos, heart defects, choanal atresia, growth and/or mental retardation, genitourinary abnormalities, and then ear anomalies and/or deafness. We actually don't use this criteria anymore, but it is, a lot of us learned it, and so it is a way to kind of tip us off to the diagnosis. Now we basically know it's linked to an abnormality in the CHD7 gene, which can be tested for. Not cheap, but it can be tested for. And the temporal bone abnormalities are what's associated with facial paralysis. And then there's craniofacial microsomia, which is, this is kind of omics term now. It's a bit of an umbrella term that encompasses a lot of related syndromes and processes. So craniofacial or hemifacial microsomia, also at times it's called Goldenhar's, often at times it's called oculoauriculovertebral syndrome. There's a lot of crossover with other syndromes that affect the first and second brachial arch. So you'll see, bony and soft tissue abnormalities of the mandible, the ossicles around the ear. In terms of these syndromes that are related, like branchiotoretal syndrome and Treacher-Collins syndrome, they'll typically have better facial symmetry. So this is branchiotoretal syndrome, this is Treacher-Collins, than a child with craniofacial microsomia, which you can see why at times it was called hemifacial microsomia. Treacher-Collins, you have this malar hypoplasia, which doesn't support the globe very well. They have the down slanting palpebral fissures. Branchiotoretal syndrome, pretty good name. It basically has periauricular and possibly hearing abnormalities as well as some renal involvement. This is the classic lop ear deformity you see here. So that's sort of the differential diagnosis with some focus on some of the causes a little bit unique to children. And then I just wanted to give you guys a quick run through of the various options that are available for working these kids up and the treatments that are available. So workup, the main goal of the workup is to identify a diagnosis with the hope that we can do something about it. Some diagnoses we can't do anything about. And really where I'm coming from is that, I see people too frequently that come in, they've had facial paralysis for 7 years, it's not getting better, and they say, I have Bell's palsy. Well, they don't have Bell's palsy. Those people need to be imaged again, even if they've already had imaging, to look for things like facial schwannomas, which are very slow-growing tumors of the facial nerve, etc. As you guys know, in a young child with facial paralysis, as with any significant medical issue in a child, you often need a multidisciplinary team. Otolaryngologists are a good person, kind of a good first person to refer a kid with facial paralysis to. Pediatric otolaryngologists are very good at figuring out the implications of some of the syndromes that have a lot of manifestations in the head and neck. I'm a facial plastic surgeon. We're good at kind of knowing all the non-surgical and surgical options available to improving the function of the face. Otology is another subspecialty of ENT, and those surgeons are useful to sometimes explore the middle ear space or the mastoid space to look for abnormalities of the facial nerve or pathology in the middle ear. And depending on circumstances, the workup may entail electrophysiologic testing. There's something called electroneurography where you can kind of see how many signals are getting through the facial nerve on the affected side versus the normal side, and that can give you some information that is useful for prognosis as well as determining what to do next, as well as facial EMG, which looks more specifically at individual muscles and branches of the facial nerve. Radiology can be very useful, so if you're really trying to look at the full course of the facial nerve, things that are particularly helpful are temporal bone CT, which is a really high detail look at the temporal bone and the passage of the facial nerve, and then a cranial nerve 7 protocol MRI. There's one recent interesting study that when you looked at kids with facial paralysis, that 32% of them had some abnormality of the facial nerve itself visible on CT. And then, to me, even more interestingly, they took 9 of those kids to the OR and did kind of a mastoid exploration. And all 9 kids, they found an abnormal facial nerve in the mastoid segment, despite the fact that they had normal imaging. And that is useful information. So synkinesis is, so the negative outcome after Bell's palsy, kind of jumping back to the beginning, is not persistent facial paralysis, which I told you never happens and should be worked up further. The negative outcome is what's called synkinesis. So the nerve gets injured, and then when it recovers, the axon destined for your orbicularis oculi muscle goes to your orbicularis oris instead. And so when you try to smile, your eye closes, and when you blink or, close your eye, your mouth moves. And it really is, really disturbing socially for patients who are affected by this. They often look pretty good at rest, and so as you can see, this is a very common, 45-year-old woman who got Bell's palsy during the third trimester and comes to see you, and, she looks pretty symmetrical at rest. And then when she tries to smile, you can see, this eye really closes, her eyebrow has actually raised somewhat, the corner of her mouth does not come up at all. She has a lot of tethering in the mentalis. You can see the platysma band here that's forming, and a lot of times they get what's almost called like a frozen smile. So all the muscles that want to pull down on the corner of the mouth are kind of winning the fight against the muscles that want to pull up on the corner of the mouth. And fortunately, this is kind of an interesting way to look at these patients. So I took her face, basically in this picture on the right, and split it in half, and then copied it to make a new face. And so you can see clearly smiling on the normal side. A lot of these patients actually get extra movement on the normal side because they're trying so hard to move the side that's not moving properly. So she kind of looks a little like Crazy Eyes, if any of you guys watch Orange is the New Black, like a little too happy. Whereas on this side, clearly not a positive expression. And, if you were married to this poor woman, it would be hard to know if she was happy with you or upset with you, which I also have trouble with my wife. So fortunately, Botox is a godsend for these patients. And basically, you just try to weaken the muscles that are working abnormally. So in this woman, kind of symmetrically, you don't want to kind of only treat the affected side because then they look aged on one side and not aged on the other. So symmetrically treat the forehead like I would with any cosmetic patient. Give a little bit more around the eye, crow's feet, and even sort of medially, which is not somewhere I would normally give it in a cosmetic patient. And then a touch on the crow's feet on the other side just to balance out her face. And then really, weaken this mentalis and platysma muscle. And then you can see here, the depressor anguli oris, which is the muscle that's affected in congenital unilateral lower lip paralysis, or CULP. So she's pulling down on the normal side and not on the other. And you really don't need this muscle to function in daily life, so we actually weaken it for symmetry. And afterwards, it's not perfect. It's really hard to get these eyes not to close a little bit. But at least she's smiling. The corner of her mouth is turning up a little bit. So these patients are very thankful. And there is, some benefit also to doing occupational therapy. There's very few people who are good at this in the country. If any of you know somebody in the Twin Cities that's good at this, I would love to meet them. There is one of the best in the country in Madison, Wisconsin, named Jackie Deals, and so I've been sending the patients to her. There was a time when we thought electrical stimulation was helpful to nerve recovery. Probably, if I look at all the human clinical data and all the animal data, it probably is more harmful than helpful. It probably actually causes more synkinesis, and so we don't really recommend electrical stimulation after facial nerve injury. But just, these people actually get a lot of tightness in their face too. They'll complain of chronic tightness and discomfort. And so just stretching out those muscles is helpful. It gives them a lot of relief of that pain. And then neuromuscular retraining to just try to generate a more symmetrical smile. So surgery for chronic facial paralysis. I know you guys, a lot of you aren't surgeons, but I think it is, again, useful to know what interventions are available in case you have patients who are asking about it. So there's sort of 5 goals from a surgical standpoint of treating these patients. Most importantly, protect the eye, which again, very simply can be done with hydrating drops and then like lacquer lube, which is essentially Vaseline in the eye at night, which is thicker and stays on there while they're sleeping. Then I would say the next sort of tier of goals is to give them good resting facial symmetry because we spend 90% of our time with a blank facial expression, and at least if they can go to the grocery store and not feel like everybody's looking at them, that's very valuable to them. Restore function, so things like oral competence. I like to go out to eat. I think a lot of you probably do too, and if you are drooling, you're probably not going to go out and eat, and that's a huge effect on the quality of life. Something that's often forgotten about is the fact that if the face kind of all pulls to one side, then they often have difficulty breathing on the side that is affected, and there are multiple things you can do to improve nasal breathing on that side. And then, the thing that's really fascinating and very difficult to achieve is to give them a smile back. So, intermittently in the media, there's, focus on the quote-unquote smile surgery. And there's multiple ways to try to give somebody a smile back, but the only way to give somebody a spontaneous, emotive smile, so when they laugh, for example, is to do basically a two-stage surgery called gracilis muscle transfer, which I will show you in a little bit more detail. The kind of three basic operations you do. So if you know where the nerve is injured and that injury is kind of outside the skull base, then typically you can just repair it primarily or graft it. If it's inside the skull base, then usually you can't get to the two edges of the nerve to repair it, although I know surgeons in Europe who try to do that with mixed results. So this would be somebody who had a skull base fracture and the nerve was like transected just distal to the brainstem. And in those people, you generally try to do what's called nerve substitution. So you take another motor nerve in the face and you actually use it to drive the facial nerve. And that assumes that the facial muscles are intact. So if your facial muscles are atrophied or they're removed by a gunshot or something like that, it's not really worth doing that. And then regional or free muscle transfer. So this is basically, if it's been 2 or more years from complete facial paralysis, generally the muscles of the face, even if you bring axons back to them, they will just not work. They've kind of turned into scar tissue. In those cases, you actually have to bring new muscle to the face, not just new nerve. So nerve substitution, classically, again, I'm not going to spend a ton of time on this, but just so you guys have a little bit of basic knowledge. Classically, the hypoglossal nerve, so the 12th nerve, was used. They used to just cut the whole 12th nerve in half and sew it to the facial nerve, which paralyzed half the tongue. So that's really, stealing from Peter to give to Paul. And it had pretty significant impact on quality of life from a speech and swallowing standpoint. So then people figured out, maybe we can just take half the 12th nerve, and they would do these little jump grafts. And that's actually a pretty good surgery. It gives you nice facial tone, so at rest your face is pretty symmetric. More recently, I'd say in the past 5 years, sort of the hot donor nerve is the masseteric nerve, so that's the nerve to the masseter muscle. Some potential advantages of that nerve over the 12th nerve, you have 4 masticator muscles on both sides, and so if you completely denervate the masseter on one side, you're really only affecting 1/4 of the masticator on one side and 1/8 overall. So people tolerate it quite well. There's really no risk to speech or swallowing, so in patients like people who have NF2, neurofibromatosis 2, who are going to probably have bilateral cranial neuropathies at some point, it's useful. It's a smaller skin incision. There's a lot of crosstalk between the 5th and 7th cranial nerves in the brain we're finding. The motor nuclei are very close together. And it's just really easy for people to learn how to, you basically have to think to bite down and then their face will move. Whereas with the 12th nerve, you had to kind of push your tongue to the corner of the mouth, and it's just not a common movement that we do, so people had a hard time using it. And then at the same time, you can do a cross-face nerve graft, which is, I'll talk about in a second. This is, hopefully doesn't gross any of you out, this is kind of an intraoperative look at doing the masseteric facial nerve transfer. So it's a parotidectomy type incision, which is somewhat similar to a facelift type incision. And at least the way I like to do it is kind of lift the superficial lobe of the parotid up with the skin. That way you haven't disturbed the plane that you would use for a gracilis flap in case you decide to do that later. And this is the facial nerve here. And really you want to kind of find, this is called the pes anserinus, which I think stands for goosefoot, sort of the division into the upper and lower divisions. And you really want to find the upper branches going to the forehead and the eye so you can try to preserve them so that once you give new axons back, they can actually reach their muscles. And then this is after kind of dug into the masseter muscle through this approach and found the nerve to the masseter, which is here. And then this is the main trunk of the facial nerve, and then under a microscope you sew these together with very, very, very fine suture. And this is just one of the patients that we did out in LA. She's probably the best result I've ever seen. She was super highly motivated about her appearance. I think she'd had 4 breast augmentations, and She'd had multiple surgeries. But this is her before at rest. This is her before trying to smile. This is her after masseteric facial nerve transfer at rest, and this is her smiling. So really, this just shows you what's possible. Not every patient gets this result, but I have a feeling she spent 5 hours a day in front of a mirror working on it, which is great. I mean, that's how you get a good result. So muscle substitution, if you've had facial paralysis for more than 2 years and just have had no movement, then you got to bring new muscle to the face. So you can do that regionally. So you can take muscle somewhere in the head and neck, or you can do it distally. The kind of new hot muscle transfer is called temporalis tendon transfer. So you're actually, again, taking one of the chewing muscles, and it's from a system that has a lot of redundancy, so it's well tolerated. We used to actually kind of cut the temporalis off the skull and flip it over the zygoma, which was not the direction the muscle was meant to work, and it created like hollowing in the temple and like fullness over the zygomatic arch. So you're kind of making somebody look bad, but maybe they had a smile. It just didn't make a lot of sense. So this is a much more cosmetically appealing result. And basically, the other kind of interesting thing is, particularly in older people, on the side with facial paralysis, they'll have no nasolabial fold, they'll have no smile line. So that adds a lot of asymmetry because they typically have a pretty deep nasolabial fold on the intact side. And so by making an incision where their nasolabial fold should be, you're actually helping them. I mean, usually we try not to put cuts on the face, but this is a good cut. And you dissect basically all the way down through this incision to the ramus of the mandible, and then you cut the temporalis muscle off the mandible, and then you sew it to the corner of the mouth. And this is one of my patients from locally who had kind of a neglected basal cell carcinoma, actually, that in the end required sacrifice of the facial nerve as well as a huge skin resection. You can see this is a pectoralis muscle flap that somebody else had done with a skin graft. And the longer you have facial paralysis, the more asymmetry your face has. He was pretty short after paralysis here, but already you can see the loss of this nasolabial fold and just total flaccid paralysis. And this is about 3 months after temporalis tendon transfer. He's got better facial symmetry. His face is more even. He's got the nasolabial fold. He had been radiated. People who have been radiated a lot of times cannot generate a smile very well, just because there's a lot of fibrosis in the masticator space. But a lot of patients who have not been radiated actually, when they bite down, can get 5 to 10 millimeters of movement, which is near normal from a smile standpoint. And at first they have to think about it, and eventually they kind of get to the point where they're not thinking about it. But when they laugh, there will be no movement because, for whatever reason, kind of the emotional center of the brain works differently. So the only way to get spontaneous emotional movement, so a laugh, for example, is with, you basically have to somehow connect the good facial nerve to the affected side of the face and then get some muscle there. And most commonly, this is what's called a two-stage free muscle graft. You can take several muscles, but basically in the first stage, you take a nerve graft from the leg and you sew it to a branch on the good side of the face that you don't need. Fortunately, the branches in the middle of the face, there's several of them, and those are the ones that cause a smile. So you kind of cut that, sew a nerve graft to it, and you leave it for 6 months. And people can kind of tap on their upper lip, and then they'll feel a zing when it's grown across. And at that point, you do a free muscle graft. So this is a gracilis muscle, which you don't really need for anything unless you're like an Olympic athlete. You're not going to notice you don't have your gracilis. And you take it with the obturator nerve, which is its nerve of movement, as well as its artery and vein. And then you sew that to the artery and vein, typically the facial artery and facial vein, so the muscle will live. And then you sew the motor nerve to the cross-facial nerve graft that you did in the first stage. So then basically the brain can tell the good facial nerve, can tell the nerve graft, can tell the muscle to move. It's like a 2-year process, so you need a motivated, healthy patient who's also patient. And this does have a better outcome in younger people. A lot of places, I'd say kind of now, people over 30, a lot of times will actually do a single-stage procedure where you do this muscle graft, but you sew the nerve to the muscle to the masseter nerve that I showed you before. And so they still have to bite down, but they do get nice movement. Kind of just talked about that. This is just showing the first stage, kind of just lift the skin up. This is finding the branch on the good side of the face that you want to use. You find a bunch of branches, you stimulate them. You find one that creates a good smile, and you use that. And then you basically sew the muscle of the corner of the mouth and the temporalis fascia. And this is another patient from when I was in LA. She's another kind of great result. This shows you what's possible. I would say this is not the average result, but she had a skull-based tumor, complete paralysis here, obviously. And then here she'd undergone the masseteric facial nerve transfer, which gave her facial tone. And she's actually additionally undergone the gracilis flap. And then quickly around the eye, there are surgeries you can do. You can put a gold weight or platinum weight in the upper eyelid, which basically just helps you use gravity to close your eye. So when you try to close your eye, the eyelid, the muscles that open the eye relax, and then gravity will kind of take over and close the eye. And then these people get a lot of lower lid retraction for multiple reasons. A guy like this who's had facial paralysis for about 15 years, has loss of volume from the lower lid, so kind of loss of support. The atrophy of the facial muscles almost causes like a cicatricial process, so almost like tightening of the soft tissues of the lower lid and cheek. And then just the fact that you don't have the orbicularis oculi muscle kind of holding the lid in place. And he had multiple interventions. So he had a skin graft to kind of give him some extra skin. He had fat grafting to give him some volume back. And then he had kind of a closed canthoplasty, it's called. So hitched the lower lid, shortened the lower lid and hitched it to the bone in a more superior direction. And is he totally symmetric? No, but certainly much better appearance. And you can just tell from the sort of improvement in the scleral erythema that he's doing much better from an eye standpoint. All right. Well, that's it. I know I covered a lot of stuff, but it is something I'm passionate about, and it's not that common a problem. And there's not that many people who know a lot about it. So if you have any patients that have this, I'd love to see them and see if we can do something for them. I don't know if you guys have any questions.
We do have time for questions, and while we give Minneapolis the first opportunity, I have a question. Which, if any, or all of the procedures that you described would be applicable to a child with one of the developmental causes of facial paralysis, Mobius or charge or whatever?
Yeah. Any child with a syndromic process obviously is a complicated patient. Let's take Mobius syndrome, for example. Certainly, gracilis muscle transfer is very commonly done for that. You can actually do bilateral gracilis muscle transfer. You can actually do bilateral simultaneous gracilis muscle transfer, has been described. And you can drive that off. So, they have bilateral facial paralysis, so you can't, you don't have a good facial nerve to use, so they typically do bilateral gracilis to masseteric nerve, and then they kind of bite down and are able to generate a smile. There was a guy in Toronto, Ralph Mengtolo, who I think is retired, but he was sort of, I would say, the best person in the world doing that surgery. And it was really striking. I mean, you take a 15-year-old girl who, had prom coming up in a couple years and just had totally blank face, and then, her prom picture, she had a really nice smile, so... That's just one example. I think each patient's different, socioeconomically, what their, what other medical problems they have, where they're at from a mental standpoint.
We have any questions in Minneapolis? Not seeing any questions here in St. Paul. Yes, here.
Thank you very much for a very interesting presentation. I have felt that in the summertime, a child presenting with facial paralysis is a candidate for either amoxicillin or doxycycline, depending on the age, for the with the presumption of Lyme disease as you are doing the workup. Do you think that's appropriate and correct?
Yeah, I think that it depends on the patient. If they are totally consistent with Bell's palsy, until these kind of guidelines came out and I read about it, I was surprised to see that the incidence of Bell's palsy in children is close, if not, the same as in adults. So if it's a totally classic story for Bell's palsy, definitely do that stuff. And then if it's not totally classic, I think that, like you said, those antibiotics are very well tolerated. I think there's very little downside to adding them. So I do think that's a good idea.
I have another question here.
This is quite a number of procedures per individual. Does insurance cover all that, or do you have to be a millionaire to go through that?
It's a great question. So the surgeries are essentially always covered. I would say the biggest problem actually is, which is the most common patient, is the patient with Bell's palsy who then recovered with synkinesis, because the best treatment is really Botox, and that needs to be repeated every 3 months. And insurance actually reimburses me like a little less than I have to pay to get the Botox, and so it is a bit of a problem trying to figure out how to care for these patients. You feel you can't lose money to take care of patients, as we all know. So that's the biggest problem, is basically getting some sort of reimbursement for doing Botox for synkinesis. You can do surgery for synkinesis, so you can actually permanently, say, cut the platysma muscle or cut the marginal mandibular nerve that's going to the lip depressors, and that'll be covered. And a lot of those patients eventually, kind of after seeing the benefits of Botox and getting sick of coming in every 3 months, will opt for that. But I'd say, the Botox is by far the biggest issue.
I was just going to ask a quick question if baclofen or anything like that, acting centrally, would be helpful if surgery wasn't an option, but you're saying it's typically covered.
That's a great question. So there is something called cervical dystonia. I mean, this is what I think of, which I participated in the care of several patients at the University of Michigan with that, which is, a horrible dystonia which causes typically bilateral, constant, uncontrolled facial movements. And you can give them a lot of Botox and they can get a significant improvement, but they usually still have some issues. And so, I think involving a neurologist with some experience with treating dystonias is really helpful to add things like baclofen that will, modulate spasm, etc. Yeah.
Minneapolis, any questions from your side? Appears not. Any other questions here? If not, thank you very much, Doctor.